So, hello everyone, I'm Edwige, Dystonia Europe president. I will be your moderator today with Monica. Hello, Monica.
Hello, Edwige.
Monica is Dystonia Europe Executive Director. So, welcome to our first September Dystonia Awareness Month webinar to learn about DBS Select, an interactive experience. We are together for 1 hour and a half. You can use the chat button already now to ask your questions about DBS, as we will propose today an interactive session after a short introduction. You also have the reactions button available if you wish to express yourself during the webinar. The webinar is recorded and will be proposed on YouTube afterwards. So I'm glad to introduce our speakers who have agreed to give their time and make this presentation today. Thanks for your involvement. Dr. Alexandra Boogers is a movement disorders neurologist at Schirek Hospitals in Brussels. Hello, doctor.
Hi there. Good evening. Thanks for having me.
Dr. Harith Akram is a sorry for my accent, honorary clinical associate professor and consultant neurosurgeon at the Unit of Functional Neurosurgery, Queen Square Institute of Neurology, and the National Hospital for Neurology and Neurosurgery. Hello, Dr. Harith.
Hello all.
Hello. And Dimitri Venekian was the former director of Health House, who co-developed the DBS Select program with Dr. Boogers. Their mission is to focus on patient education. The DBS Select program will be a great example of this. Hello, Dimitri.
Hello, and thank you also for having me tonight.
So DBS Select is an educational tool to better inform patients and caregivers on DBS, deep brain stimulation, which is a technique widely used to treat movement disorders such as dystonia. Would you like to tell us more about this tool?
Well, Alexandra Boogers, she came to me a couple of years ago, I think it was in 2019, talking about how patients were educated about the treatment with deep brain stimulation. And as it often goes into a hospital, patients are given a brochure or an info flyer. They have an appointment with their doctor, they get all the information, but it's only at home that all the other questions start popping up. So together we explored how can we turn this into a more engaging interactive session with the patients, that we try to focus on the question patients have, but based on validated research on the clinical things that happen, how can we inform them best? So we created an entire physical journey in a location in Belgium, in Leuven, where actually we take them through the entire flow. And this was also later transformed into a digital tool because we want to expand this project also more on a scalable level within different countries. And that is actually where we are today, that the project is also being used as an online experience to educate patients on the DBS treatment. So this is how the tool is nowadays also being used.
Great. And by the way, what is dystonia?
Thank you. Thank you, Edwige. Thank you so much for this question. And before I'm going to answer that question, as Dimitri said, DBS Select is a tool to educate people, and you'll see, over the course of the next hour that every now and then you'll see a visual aid that will support whatever me or Dr. Akram will be explaining. But education is very important and needs to be done in several ways. For instance, during a webinar like tonight, which is an excellent floor to actually talk about DBS for dystonia. But yeah, dystonia. I don't think that you guys need a lot of explanation about this topic because you are apparently very familiar with it. But dystonia is a muscle contraction, like an abnormal movement of our muscles that contract, which can be a little bit tremulous, rhythmical, and dystonic, which means that a fixed posture can be assumed of a certain limb, for instance. And dystonia can be in a part of the body, but can also be all over the body. And in that case, we would call it generalized dystonia. But for instance, cervical dystonia can present itself in patients, or just the eyes. In that case, we would call it blepharospasm, or for instance, the eyes and the neck together. And obviously, this puts quite a burden on patients and on their daily lives, because it's a very obvious disease, right? When you pass a child in the street, a child who may not be hesitating may say like, oh, that woman or man is looking like with a face to one side. But it's not only that, because often dystonia patients also have a significant amount of pain, for instance, in their neck or in their hands or feet. So that's very important to know as well. And my job as a neurologist is not just doing the diagnosis, but also part of the treatment. And before we tap into treatment, it's important to know or investigate why the dystonia is actually there. And very often we may not necessarily find a very defined cause. We will try to exclude what we call secondary dystonias, for instance, a dystonia that has its onset after certain drugs were taken or after an accident, for instance. And often we will ask about family history, whether there is another person with dystonia in the family. And then we may want to suggest a patient to have genetic testing done to then arrive, hopefully, at a very good diagnostic. For instance, you may have heard of a disease which is called DYT1, which is one specific gene that causes dystonia. And once we've elaborated on what kind of dystonia it is, we may want to suggest treatment. And treatment will, first of all, be oral drugs, a drug that may be called trihexyphenidyl. And after drugs, we would, if these are insufficient or not well tolerated, we want to, for instance, suggest going for botulinum toxin injections. This can be, for instance, rather efficacious for the eyes and especially for cervical dystonia. But people with generalized dystonia, for instance, so people who have dystonia not just in the neck, but maybe also in their hands, maybe sometimes even in their trunk and their feet. For these people, we may want to suggest or talk about deep brain stimulation, right? And this is what the topic of tonight will be. Now, maybe I want to pass the word to Dr. Akram for a second, who is stellar in explaining what DBS is, right?
Thank you, Dr. Boogers. So yeah, hello everyone. I've just to give you a bit of a background. I work in the biggest unit in the UK that does deep brain stimulation. So we've been doing deep brain stimulation since 2002, and we do about 150 new implants a year. So we what deep brain stimulation involves is implanting 1 or 2 wires in the brain, and that's done with imaging, so image guidance. We get an MRI scan of the brain, and then we know where the target is in the brain, and we use something called a stereotactic technique. So we use a frame that is fixed to the head with 4 screws, and that frame will then guide this wire into the brain in whatever target we want to choose. So we don't only treat patients with dystonia. Most of our patients actually have Parkinson's disease, and we have patients with tremor, and we have patients with dystonia. The target in the brain for dystonia is called the internal pallidum, and usually we operate on both sides of the brain. So we would implant this wire on the left and on the right, and this is what it looks like. As you can see, at the tip of the wire, or the DBS lead, you have those electrodes, and you usually have about, traditionally we used to have about 4 of those. Now we have newer DBS leads where we can steer the stimulation current via what we call directional electrodes, directional contacts. the wires are all implanted. Once the wires are implanted in the skin, they're fixed to the skull, and the hole in the skull that we drilled to put the wires through is then capped, and then the wires are all passed under the skin to a pacemaker, so a small battery pack, usually just in the chest, so under the clavicle, and that battery pack will generate, kind of will stimulate the brain and in that specific target continuously. Because once it's switched on, it will just send an electric pulse into that target in the brain. It's most new devices are rechargeable, which means that patients will have to charge these about once a week or once a couple of weeks, but not all of them are rechargeable. I know that patients with dystonia sometimes have trouble charging, for example. So we can also use batteries that are what we call primary cell. It means that they don't need charging. The problem with that is that with time, they will run out of juice, run out of battery, and then we have to replace them. Every time we do that, there's a risk of infection. The rechargeable batteries tend to last much longer, so they can last, depending on use, but up to 25 years. So in summary, what is DBS? It's not, DBS is not a cure, but it's another way of controlling the symptoms, just like you had Dr. Boogers talking about medications and talking about Botox. This is another way of helping the symptoms. And what it's doing is it's sending this electric signal, this electricity, into the targets of the brain that will then modulate the brain to help with the dystonia symptoms. We don't actually understand how dystonia happens in the brain very well. I mean, we obviously know what happens, but it's something to do with something called plasticity in the brain. And we think that by stimulating these targets in the brain that are part of the basal, what's called the basal ganglia, we can modulate that plasticity in the brain and reduce those unwanted symptoms.
Thank you. Can I jump? I have a question. You say that DBS is not a cure, so which type of symptoms could be improved?
So it's very good for dystonia symptoms. We know it's very good for patients with primary dystonia. So it's not very good for secondary dystonia. It might help a little bit with secondary dystonia and things like pain, for example. But in primary dystonia, and especially in generalized dystonia and in certain types of focal dystonia and cervical dystonia, it works well in most patients. The first thing that improves that I see is pain. So if you have pain with dystonia, you switch the DBS on and potentially within hours, pain will go away. And then with time, it's not a switch, but with time, the other dystonia symptoms will start to improve. So you get, if you have, for example, cervical dystonia, then, you'll stop getting the pulling. Now, but if you have a fixed deformity because you've had the cervical dystonia for a very long time, that's not going to improve. If the neck is fixed, the neck's fixed, but the abnormal contraction will get better. Similarly for generalized dystonia, you get a lot of the abnormal contractions will get better. Sometimes patients will improve by 90%, 95%. Sometimes you can't even see that they have dystonia. Other times, we get about 40, 50% improvement. There's very, very it's very rare to not have improvement in dystonia with DBS in these conditions. But yes, there are other conditions where we don't really have enough evidence for efficacy, so I can't promise patients that they will get better. For example, if you have what we call we have ocular dystonia, you have kind of orofacial dystonia that sometimes improves, sometimes doesn't improve. Blepharospasm patients do this. Again, in my experience, you can't really promise that it's going to improve. It could improve, but because we don't have enough patients, we can't really say with certainty that it's going to improve. But there are other conditions. So we know that there are genetic variants, for example, as Dr. Boogers mentioned, and some of them we know because we know the genotype really well. We know what these genes do. We can predict the improvement really well. So patients with DYT1, we know they do really well with DBS. There is a type of dystonia called tardive dystonia or dyskinesia, which is something that can happen as a result of taking medications for mental disorders. They're called neuroleptic drugs. We know that that improves really well with DBS. So it depends on what we call so there are two things. There's something called the genotype, which is what is the genetic cause for the abnormality, for the dystonia, and that's not always obvious. And the phenotype, which is what does the dystonia look like. So I'm just a simple neurosurgeon. I don't pretend to understand these, which is why when we select patients, we always work with the neurologist, so with Dr. Boogers, who will be able to tell me which patient is going to respond and who's not going to respond.
Yeah,
Thank
indeed. I think it's very important, as Dr. Akram mentioned, that we select the right patients, right? We will not operate on everyone, and we try to inform them about the outcome and what will and what will not improve. And indeed, especially the voice, sometimes have this very distressed voice when they have dystonia of their laryngeal cords as well. And people obviously want to be understood, and sometimes we do have to be careful in what we promise in terms of voice and swallowing, for instance, if those are affected by dystonia.
Yeah. So, I mean, if I can, that's an excellent point. And actually, this reminds me, which there are other targets in the brain for these special types of dystonia. So there's a certain type of dystonia, it's called focal dystonia, which is musician's cramp, for example. And we know that responds well to another target, the ventro-oral nucleus in the thalamus. And rather than doing DBS, we actually do make a small lesion. So we go and burn that little nucleus in the brain, quite deep in the brain, and we can get rid of the dystonia in the hand that musicians have. Dr. Boogers mentioned vocal dystonia. There's a subtype of dystonia called laryngeal dystonia, and you trained in Canada. So you must be very, very familiar with, I think it, so Dr. Chris Honey described the syndrome really well and has demonstrated that targeting another target in the brain called the VIM, the ventro-intermediate nucleus in the thalamus, can improve these symptoms with DBS. So we can, as surgeons, we can tailor our treatment based on the symptoms, because we know that what we're trying to do is we're trying to help certain symptoms, rather than trying to cure the disease, because the brain doesn't work like that. The brain works by all the magic electrochemistry, and with our understanding, we try to modulate the certain networks in the brain that cause certain symptoms.
So, okay, so we talk about the different forms of dystonia, etc. So, what are the criteria for to get DBS? Who are the best candidates for that?
Yeah. So thank you. Very good question. What we at the end of the day, what we try to achieve is we want to improve the patient's quality of life. right? That's the main thing. And whenever I get referred a patient, I have to see whether I have to make an assessment of the risk to benefit ratio. Nothing comes without risk. So brain surgery can be risky, but also medications have risks. You know, you take these medications, they make you sleepy. If you work with machinery, that's quite dangerous. You know, you can drive, if you need to drive a car, you take these medications, that can be dangerous. So it's nothing comes without risk. What we want to see is we want the expected benefit to be up here and the potential risks to be down there. So for this to happen, the first thing that I need to ascertain is that the symptoms are severe enough to interfere with the patient's quality of life, right? This is not an operation to improve, you know, cosmesis. But having said that, if the dystonia is causing patients significant social distress, then, you know, that is an indication. If the symptoms are causing significant pain, if the dystonia is affecting work, you know, other activities of daily living, that and hasn't, you know, and the symptoms haven't responded to other conservative means, so Botox, EMG guided Botox, and medications, then there is an indication for surgery. So the second thing that I need to do is I need to make an assessment whether this is likely to improve with surgery or not. And this is something that we've just discussed. You know, we know the genotype, the phenotype, and then based on previous experience and evidence that we have, I can advise the patients and say, yes, I think this will improve with DBS. And then the third thing is to assess the risk. And that then becomes all the other anesthetic risks, for example, frailty, age. As you know, the older we get, the less capacity we have to tolerate a big operation, and other things like balance, for example. If patients have poor balance, then DBS in the basal ganglia is not a great option because it can affect balance. If patients are on anticoagulation, so on drugs that will thin the blood, like aspirin, warfarin, clopidogrel, because they have a stent or they have an artificial heart valve, or they've had a stroke, and they can't come off these medications because the risk is too high, then we can't operate on them because there is a high risk of having bleeding during surgery and developing a stroke. If patients have uncontrolled high blood pressure, same thing, because there is a higher risk of bleeding during surgery, so they'll be too risky. If patients have diabetes, which is not controlled, then that increases the risk of infection. Or if they have any other types of, you know, if they have other reasons to have lower immunity, like they might be on steroids because they have, you know, something called an autoimmune disease or other reasons to increase the risk of infection, then we would advise them against that. So if I kind of summarize, what are the risks from DBS? The worst thing that can happen with DBS is that you can have a stroke. And that happens because there's bleeding in the brain as we put the DBS wire in. We reduce that risk by controlling blood pressure, stopping anything that might thin the blood for 2 weeks before and 2 weeks after. It's important to note that actually there are some common pain medications that can thin the blood. So they're called non-steroidal anti-inflammatory drugs, or NSAIDs. So things like ibuprofen, Nurofen, which is the same, diclofenac, naproxen. These drugs can thin the blood, so we ask patients not to take them for 2 weeks before and 2 weeks after surgery. When patients wake up from surgery, there is always a risk of having what's called an epileptic fit or seizure. And that tends to happen in patients with a history of epileptic fits. But because we're interfering with the electricity in the brain, there is always a risk of having a seizure immediately after surgery. That risk is low. It's about 1% or lower. But if patients have a seizure, they might not, depending on the regulations in their country, they might not be able to drive for up to a year until they are seizure-free. They don't have another seizure. Another risk with surgery is the risk of infection. We all carry millions of bacteria on our skin. It's normal. We live in an environment where we're surrounded by bugs. So what we try to do is we reduce this microbial load during surgery. I give my patients special shampoo and body wash and nasal spray to use for 5 days before surgery. This reduces all this kind of the level of microbes that we carry. During the operation, I give antibiotics, not just in the vein, but also in all the wounds. That also reduces the risk of infection. It's never zero, but we can get it down, as low as 2%, 3%. Now, why do we get infection with DBS? It's a foreign body at the end of the day. There is no blood going to it. So our white cells, which will fight infection, can't get into the device. So what we don't want is we don't want a bug to find its way to the device, latches onto it, and then wait until our immune system is low for any reason and then starts to multiply and cause an infection. Because if that happens, the only treatment will be to remove the device. We can't treat it with antibiotics. As I said, there's no blood going to it. This is particularly important in patients with dystonia because once the brain is used to the electricity and to the stimulation, and the symptoms are under control, the brain is kind of it's used to it. If we switch the device off immediately, we might get something. There's something called rebound of symptoms. There's a condition that's called a dystonic crisis, which could happen. So the symptoms can come back, but even worse than before. And that can actually cause, some patients might need to be anesthetized. They might need to go to ITU and be on a ventilator to stop these symptoms. This can be very, very serious. That's why it's really important to do everything to reduce the risk of infection. Other risks of DBS after that will be when we switch the device on, sometimes patients get some side effects from the stimulation itself. That depends where exactly we are stimulating in the brain. So assuming that we are in exactly the right spot that we want to be in, and my tolerance for error is 1.5 millimeters. If I'm more than 1.5 millimeters from my intended target, I will remove that DBS wire and put another one in during the operation so that I know that I am exactly where I want to be. So once I've implanted the DBS leads, I get an MRI scan or a CT scan to check that I'm exactly where I want it to be with the patient still asleep. And if I'm not happy, I will move it. Despite that, being in the perfect place, we can still get side effects. One of them is if we're stimulating too deep in the target, patients can see flashes of light. But that's not a big deal because we have other electrodes to use, so we can change and go to a higher electrode. Patients can get if the electrodes are very close to a part of the brain called the internal capsule, we can get pulling in the face or in the hand. And that, again, something that we can reduce by reducing the stimulation. And we can very rarely difficulties in swallowing and speech problems with stimulation. That is rare, but it can happen depending on how much we're stimulating. there's also a very rare but well-recognized side effect from the stimulation is that if we're stimulating too much, we can stop movement from happening. And patients become a little, it's called Parkinsonian. So they start to have problems with walking because they feel that their legs are heavier if we're stimulating too much. It's rare, and it responds to reducing the stimulation. So because this target in the brain, the internal pallidum, is very good at stopping abnormal movement. If we overdo it, we can stop normal movement. So these are things that can happen with stimulation. Other risks, this is a device that doesn't heal itself if it's broken. So if one is involved in a car accident or maybe decided to go bungee jumping or take up kickboxing and they kind of get hit on the device, it can break. The wires can break, and we might then need to go back in and replace it. And this is something that happens. It can happen in patients with dystonia because of the abnormal movement. So if it's, for example, cervical dystonia and there is a repetitive movement, that can then put strain on the DBS lead or the cables, and they can break or they can migrate. And there are things that we do to prevent that from happening. So that there are technical things that we can do to reduce these risks. The battery itself can also sometimes slip and move or flip in patients with dystonia because of abnormal movements. Again, these are things that we can mitigate against by doing certain technical things during surgery. And there's something called a disease burden. A DBS burden. When you have the implant, you still have to look after it. You have to keep it charged, and you live with the knowledge that you have a pacemaker, and that's there are cultural there's certain cultures that don't like having anything in their body. I know that the Japanese, for example, don't like to have DBS because they don't like to have anything in their body, and other cultures are completely open to it, but at the end of the day, this is something that will be with the patient for life, potentially. So, and there is a commitment to seeing Dr. Boogers every year to check that it's working. So you can't just have it and then forget about it. There are new systems that can do programming and checking on the device remotely. So that reduces travel, for example. So I know that Abbott system has that, and I know that the other systems are also in the process of introducing this, so that can reduce that risk. And the last thing is there are some restrictions when having DBS in. So you can't get an MRI scan without certain precautions. Almost all the new systems are MRI conditional, which means you can have an MRI scan, but we need to make sure that the circuit is intact, that there is no short circuit, and that some devices will need to be put in a certain MRI mode, and that we have to reduce the energy that we deposit in the body when we get an MRI scan. I think I talked too much, don't I?
You are addressing already a lot of questions, but I have some precise ones.
Thank you. I need to give someone else a chance to speak, so I'm sorry. Next time, just stop me.
About the criteria, is there any age limit to get DBS?
So it's not the chronological age as much as it is the biological age. I remember once seeing a patient in clinic who was in her 80s. She didn't have dystonia, she had Parkinson's disease, and she wanted DBS. And when I said to her, but you're in your 80s, you want to have an operation on your brain. And she said, well, doctor, I need to get better because I'm my mother's main carer.
Okay.
So it's we see patients who are in their 60s who look like they're 80, and we see patients in their 80s who look like they're in their 60s. I think generally speaking, probably I would avoid DBS after 70, but I have operated on patients in their 70s. So it's not a hard no. Again, all depends on the biological age rather than the number of years.
So did this lady get it, the 80-year-old?
No.
No.
No. I was nearly convinced, but
Okay, good to know. And so, if I am eligible to DBS, what's happened to me? I mean, at the beginning with my neurologist,
Yeah.
we talk about DBS. So, what are the different steps?
Maybe we should indeed talk a little bit about the preparations that need to happen whenever you go for surgery. Obviously, it's going to see your neurosurgeon, as Dr. Akram already explained us all the different side effects, right? Because this is really what the neurosurgeon really tries to do very extensively, is walk you through all different risks of the surgery, of the anesthesia, and then later also of the stimulation itself. Sometimes, but this is mostly for people with Parkinson's disease, a neuropsychological test may be asked to do, but this is not very often the case for people with dystonia. Rarely we ask the patients to go see a psychiatrist, because deep brain stimulation is quite a big change in your life and in your routine, in your daily routine. And we do want to exclude that any psychiatric disease is ongoing, like depression, for instance. Most importantly, it's very, very necessary to have a good MRI of the brain being done before surgery, because Dr. Akram already alluded to the fact that a frame needs to be mounted onto the head at the start of the surgery, and that frame will allow us to go to the exact location in the brain where we want to be, right? We want to be so precise, so if we want to be within 1.5 millimeters from where we want to be, we have to be prepared to the best of our abilities, right? And that is what an MRI brain will help at. And then filming and scoring of the symptoms is very important as well. For instance, in Belgium, this is necessary to get reimbursement from our government for deep brain stimulation, but also to be able to really assess the effects of what a surgery really does. Because sometimes both the patients as a family and even the clinicians have what we call a recall bias, that we kind of forget what the dystonia really was before the surgery. And having a video at hand to be able to compare the effect before and after the surgery may be actually very important. So this, you have to take into account that every hospital has a bit of a delay or has a bit of a time period that you need to take into account running through these different examinations. And in some hospitals, this may be a few months, but in other hospitals, there may be a waiting list that you do have to take into account. There is another thing that maybe I want to jump to. Hold on, let me have a quick look here. And that is programming, because we already said that the brain stimulation needs to be programmed. And hold on. The brain stimulation needs to be programmed. And there you go. And this may take a little while before the perfect settings are being found, right? Sometimes this can take up to a few months, and we do ask patients in their setting at home to either make videos or make some adjustments themselves. And to be able to make these adjustments yourself, a remote control will be handed to the patients and their caregivers. Now, Patients who do not feel comfortable using a remote control, they don't have to, obviously, right? Because some people say, oh, I don't want to touch the device at all. Well, there's another subgroup of patients who actually like it to explore a little bit these settings. And so this is, for instance, one of the remote controls that are available. The other ones look slightly different. And this is either to adjust the voltage of your deep brain stimulation device or even switch programs. Because especially in dystonia, the rate of response is rather slow, meaning Dr. Akram already mentioned that pain may go away after a few hours, but the effect of dystonia may come to a few days to a few weeks. And that is why sometimes we ask patients in their home setting to make some changes or to assess different programs. And that is something that you could do using a remote control, for instance. So very important to take into account when the brain stimulation for dystonia is being programmed, that this is not an easy fix. It's not a quick fix. And in the research world, we're doing amazing efforts towards programming, for instance, based on imaging, or for instance, based on brain waves, to make this more easy and more convenient, both for us as physicians, but definitely for the patients. But you do have to keep into account that this is going to be a process of several months before the perfect stimulation parameters are being found.
Okay, thanks. And about the pre-ops, you said that you measure the expectations. Do you check that the patient expectations are the same of the medical side? I mean,
that's a very fair question. That's a very fair question, and I do believe that as a neurologist, that is my most important job. That is making sure that the patient knows what to expect and that everybody is aligned. And it's the most important, but also the hardest part of the job to make everybody aligned, right? If someone is expecting to have 100% improvement, that is not a realistic improvement, right? Earlier, Dr. Akram mentioned a 40 to 50% improvement in some dystonias. We do know in advance that these dystonias respond very well, and then we're talking about 80, 90. Going to a full 100, that is a rare lucky case every now and then, but that is definitely not something that you should keep as an expectation. I mean, being able to, for instance, people can be with very severe cervical dystonia, may have a hard time walking, for instance, or need a cane to keep their balance. And a realistic expectation may be that the head comes to a more neutral position so that they can see actually the road and they will be more balanced in their gait. But if they ask us like, hey, can I run a marathon by next year? You know, we have to be realistic in that regard.
Okay. And you talk about psychological disease, such as depression. Yeah, it was a good remark I have noted, because most of the time we know that dystonia people have depression and anxiety.
Sure.
Both or one. So is it depression in general, or is there any level?
Well, depression is you have severe depression, you have mild depression, and there's severe dystonia and mild dystonia, right? So it's very hard to give you one clear answer that is applicable to everybody in this sense. But DBS will change not just your dystonia, but also a part of your body image and your independence, what you can do in the household, what you can do for your children, for instance. And all of this it's impacting an ecosystem, right? It's not just impacting one single muscle. And that is why I believe it's important that we are there as a team, and a team preferably also including a psychiatrist, that if there are questions or concerns in regard of mental illness, that we can be there for the patients.
Yeah, I mean, if I may add to this, I think the other thing that we need to why we get these tests is, and as Dr. Boogers said, it's not usually common to get neuropsychological tests for patients with dystonia, but patients with Parkinson's disease, for example, get, as part of the illness, they can get a lot of mental health problems and depression, and but patients with dystonia are not immune to mental health problems. So, for example, if I have a patient with severe depression or with previous history of suicidality, and I can, sense that there are potentially social concerns, social issues. Maybe the household is there's some issues in the household. There is not enough support in the community, for example. And we know that mental health support is not great everywhere. It's rarely really great. What I want to do is I want this patient to be supported. So I want this patient to have someone either at home or in the community who's going to be able to look after them in case of crisis. In case if I've done an operation that caused complications or didn't work, and then the patient has a crisis because they were expecting that this is going to be a miracle and it didn't work that way. I want to know that they will be supported rather than they'll hit a wall and then they'll need help. So that's, I think, one of the main reasons why we get these done. On the other hand, patients with dystonia are understandably, anxious, and anyone who's having a brain operation should be anxious. If they're not, then there's something wrong with them. But anyone with, dystonia, severe dystonia can be they can have physical regression, they can have social regression, they might lose their jobs, and that will cause, the mood, they'll cause low mood and can affect patients in that way. So if we treat the symptoms, and we will also improve mental health in that sense. It's not, when we send patients to see a psychiatrist, it's because we want them to be supported, not because we want to put them off surgery or tick that box. It's all, we all work together as one team. One other thing to say, and this is something that psychiatry and neurology is really, really important in all movement disorders, not just in dystonia, is that there is something called a functional movement disorder, which means that it's not well, I have to be very careful what I say. It's not the same dystonia that is caused by a genetic problem or kind of a plasticity issue, but a psychological cause for it. The patient may not know. So it doesn't mean that the patients are pretending that they have a movement disorder. For them, it's completely real, and it's obviously coming from the brain. Everything comes from the brain. But we know that in those patients with a functional movement disorder, that DBS doesn't work. So we can't put them through the process without excluding that. And that's sometimes easy to exclude because we can see that, the symptoms are distractible, for example. There are some certain telltales of, the dystonia features that we know are not 100%, and then that raises concerns. But sometimes it's very, very hard to tell if dystonia is functional or not. And I suspect most neurosurgeons who do this type of surgery would have operated on patients with functional movement disorders at some stage of their career, without realizing it until later.
Yeah, it's sometimes very hard to distinguish functional from non-functional dystonias, and And that is why sometimes we have these meetings with different neurologists together to be able to really select the right patients. For instance, people who have a very fixed posture of their dystonia are slightly more, have more of a higher risk of it being a functional than a non-functional dystonia. You already said distractibility and trainability sometimes is a marker as well. And for those patients, as said, DBS will not work while physiotherapy is usually the treatment that definitely helps these patients.
Okay. So if I well understand, it's a multidisciplinary team who will decide that the patient can be selected for DBS.
Dr. Boogers.
All of us together.
Yeah, I mean it's an MDT decision at the end of the day, and it's not just us with the patients and the patient's family. So it's we're all on the same side. So when we come to a decision, as I said, we go back to weighing up the risks and the benefits. And if I'm happy that the benefits outweigh the risks, then I will offer it to the patient, having discussed with everybody else. And then it's the patient, ultimately, it will be the patient's decision whether to have the surgery or not. It's they're the ones who are going under the knife.
I like the fact that you alluded earlier to the importance of having a community and family. I think it's extremely rare that we operate on someone who does not have any family whatsoever or any support whatsoever. Having a caregiver, being a brother, a sister, a child, a mother, a neighbor, is extremely important for the care of someone undergoing deep brain stimulation.
Yeah, absolutely.
And Dr. Akram, I have a main question. Why are dystonia patients sleeping during the operation, the surgery, and not the other one? I think like Parkinson or essential tremor.
Well, to be fair, I mean, I do most of the operations asleep, not just for dystonia, but also for Parkinson's patients. The only patients I operate on awake are the tremor patients who are having a thalamotomy, a lesion. So even the tremor patients who have DBS, I do that asleep.
Okay.
So for starters, why? Because it's very difficult for dystonia patients to stay still with the frame on. It's very uncomfortable for them. So it's really difficult to do the surgery with them awake. But we have to go back to why we used to do surgery on patients awake. And disclaimer here, there are certain surgeons who do operations awake, and that's the way they do it. And there are different ways. When we say there's more than one way to skin a cat. But the way I do it is with the patients asleep, because I think this is the most comfortable for the patients and for the surgeon. And the reason why we're able to do this is because we have worked really hard on our imaging, on the MRI scans that we get. And the MRI scans that we get show us the target really, really well. So that's one thing. And then we work very hard on our surgical technique so that it's not just about seeing the target, but we know that I'm going to hit that target 95% of the times. And then if I didn't hit it in the 5% of the times, and I can see that on the MRI scan or the CT scan straight away, I can go and move that DBS lead. So that way, I don't need to have the patient awake. The reason why we have the patients awake is because we want to test that we're in the right place. We want to start the stimulation and check. Now, that's not really very useful in dystonia anyway, because we don't see the results straight away. But even in patients with Parkinson's disease, it's very uncomfortable for these patients. I know that ultimately the key to success, obviously, it's patient selection first, and then being in the right place based on the MRI scan. So if I can get my DBS lead in the right place on the scan, and I know it's the right patient, I can tell with confidence that this patient is going to do well. I don't need to have them awake for the operation. So yeah, so I think most dystonia patients will have surgery asleep, almost all of them.
Thank you. Because we see a lot of different things on the internet, and that's why it's important to get the right information.
Yeah.
And we talk about the constraints. You talk about MRI to be careful with. Are there any other constraints when we have DBS?
Well, I mean, anything that will have a no pacemaker sign, then we should avoid. So we talked about high, big magnets like MRI scanners, but there'll be high electromagnetic fields, high power fields. Most people are not exposed to those. But if you work in an environment where there is arc welding, for example, so you shouldn't do arc welding. Going through security gates at airports, that can affect the DBS battery and can switch it off. So the new airport security gates are X-rays, which is absolutely fine. Very, very low X-ray dose. But the ones with the metal detector ones, they're not fine. We give you a card to say that you have a pacemaker, and they will know because there are millions of people with cardiac pacemakers out there. So it's not a rare thing. That same goes for using the handheld metal detector, because that can switch the DBS off. The last thing you want is for the DBS to switch off at an airport and you don't have your remote control with you so you can check or switch it back on, which is a reason why you should always have the remote control with you if you're traveling, because in case of emergency, you can use it to check that the device switched on, switch it back on if it switches off for any reason, or if you had to have an emergency operation, they can use that to check the device. During surgery, we use one of the tools that we use during surgery, any type of surgery, is called diathermy. And it's a way of, it's almost like an electric knife that we use to cut through tissue and stop bleeding. If you have a DBS system in, then you can't have a type of diathermy called monopolar diathermy. Now, this is not something for patients to worry about. It'll be the clinicians who will communicate. So whenever we have a patient who's having an operation, the surgeons usually get in touch with us, and then we'll say to them, you shouldn't use monopolar diathermy. There are other ways of doing the same thing. There's something called plasma blade that is safe, and bipolar diathermy is safe. Other thing to watch out for, again, infection. This time because of bacteria that finds its way into our bloodstream. So that can happen at any time after the surgery. 10 years, 15 years after the surgery. If you have if you're having a dental procedure and you're getting your tooth removed and it's infected, then there is a chance that bacteria might find its way through the blood into the device, and that can cause an infection. So what we say to dentists is, if you're doing this in a patient with DBS, then you have to give the patients antibiotic cover during the procedure. Again, this is something that people do for not just for DBS, but if you have a cardiac pacemaker, if you have a artificial heart valve, any foreign body that's implanted, and it's in contact with blood, then we would advise antibiotic cover for these procedures. But the aim from the operation, again, I know it seems like there are a lot of restrictions. The aim is to improve the quality of life. So we have to justify that the symptoms are bad enough that we can put up with all these other restrictions, but in order to give the patients their lives back. So these are all relatively low risk and kind of low complication rates.
Yeah. I'm learning a lot. And you talk about the device. So there is a battery. How does it work?
So the battery, the battery is basically a computer, and it has a battery pack, and it's something that we can program to deliver an electric current. It's completely sealed, so water can't get into it, and we'll program it to deliver continuous high frequency stimulation. So there is an electric wave that we're delivering to the brain, and it's it will we control the pulse width, we control the frequency, and we control the amplitude, and we also control which electrode we stimulate, and if we have current steering, then that's something else that we can do. And that battery should last for about a month for each charge, depending on how much we're using it and how new it is. But we ask patients to keep it charged up once a week, top it up, basically. So it's much better than having your phone, because your phone, you'll have to keep it charged every day. Whereas this, you're sitting down, you're watching TV or you're reading a book, and what you do is you wear a sling that goes around your shoulders, and it has a battery inside it. That battery is charged separately in a charger. So you're not plugged into the mains. The battery is not plugged to anything, but it charges through the skin with induction, just the same way that you charge your electric toothbrush. It will charge that way. You know that it's in the right place, because usually when you put it on, the battery will beep. And then when it finishes charging, it will beep again, that it's done. And you can see the photo there. It's quite easy to do. I mentioned this already. Very rarely, in very severe generalized dystonia cases, patients don't have the dexterity to charge. And even then, if they have a carer that can charge for them, I think that's still preferable to having a non-rechargeable battery. But because the rechargeable batteries are also smaller than the non-rechargeable, and they last longer. But if we know that it's not possible to charge, then in that case we will use non-rechargeable.
Okay. And how long lasts the rechargeable or non-rechargeable one?
So the rechargeable battery can last 20 to 25 years, and after that we replace it. The non-rechargeable battery can last anything between 2 years and 6 years, depending on how much we use it. So there's some patients who need just a little bit of electricity, whereas others will need quite a bit. And on average, I think we replace these batteries at about 3 or 4 years. The problem is replacing these batteries carries a risk of infection. Every time we do this, there's a risk of infection. And if we get an infection, remember, we go back to the dystonic crisis. Also, if we're in an environment where the patients are not being followed up closely and the battery dies all of a sudden, then we can have that problem. Now, I think this is a good opportunity for me to show you a couple of videos so that you can understand what I mean by that. Is that okay?
Yeah.
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 Okay. So just to show you, this is on the left. This is a patient with dystonia after DBS. So you can see there are no movements.
You did them in the past.
And then we will just turn off the DBS straight away.
Wow.
Can you stand up?
Sit down. And you stretch your arms in front of you.
So this is much worse than baseline. And it happened because the DBS was switched off straight away. This is another example. This is a patient before surgery. And then, immediately after surgery, you see amazing result. But he presented after the battery died, and he had very severe dystonic crisis. You can see.
Oh, yeah.
Yeah, terrible. So we don't want to see this. This can be really, really dangerous. I'm going to show you another case, if I may, just so that we can kind of talk you through the decision-making process. So this is a patient with tardive dyskinesia or tardive dystonia. And as I mentioned, that this responds really well to DBS. But you could see when this patient was actually on the psychiatry ward when I was asked to go and see her, because at first nobody could understand why she was having these movements. They thought it was functional, as we discussed earlier. But she was so emaciated and had she actually had a scapular fracture, multiple body fractures, needed to be nursed in a padded room, as you can see. She couldn't use her phone, she couldn't feed. Her hair was falling because of she's so emaciated and not eating. And just to see, she couldn't walk. So she was in a very, very poor shape. Now, I was very worried because if I put a DBS system in this girl, and then the DBS is not going to work straight away. We know that it doesn't work straight away. So the wounds might open up. The DBS lead might fracture, it might break, or she might get an infection because she's malnourished and emaciated. Any of these things will cause a dystonic crisis, and she may not just be back to where she is now, but she might be much worse, and then that will be a death sentence for her. So what I did is, rather than do DBS, I did something called a pallidotomy. This is the old way of doing, operating on patients with dystonia, is rather than sticking a DBS lead in, I made a small lesion in that part of the brain called the internal pallidum, and only on one side, because we can't do that on both sides. So I did it on the left-hand side because she's right-handed. And then she was making these drawings this is 3 months later, and this is how this was during lockdown. So I was recording on a Zoom meeting. You can see drinking, texting.
Oh, fantastic.
What an improvement.
Wow.
Yeah.
Taking selfie.
And you can see that she definitely gained a lot of weight as well.
She gained a lot of weight straight away. So, yeah.
Normally that would have gone everywhere, wouldn't it? When you were really poor. See, yeah, you can.
So she was writing, and it's incredible. And walking, although walking is not 100% because that needs both sides, but she could still. So let's see, she could still walk, and she's walking on her bed, which is not ideal. Yeah. So let me just stop sharing, and then go back to you. So it's not. DBS is not always the answer. There are other options. But I'm always thinking about the risk of DBS not working in patients with dystonia, which is a real issue.
Thank you. And we have a question. Someone is asking if a person with DBS should avoid car charger, like people with pacemaker, for their heart.
Yeah, it's. I mean, you have to avoid any high electromagnetic fields. I think just being close to a charging station is not a big problem. Similarly, you have those um, electric hobs. So, for cooking, you have to be very careful not to put your chest on it because it might affect the device. I don't think I can't see a situation where someone will do that. But it's yeah, you have to avoid any high electromagnetic fields. I think the electric car warning first came, first came about 10 years ago when electric vehicles were a new thing. But I think now we know that it's safe, and unless if you're going to get electrocuted, I think that's not safe for anyone if you have DBS or no DBS. And I don't know, Dr. Boogers, do you agree?
Yeah, I absolutely agree that you should be cautious at the end of the day with anything you do having DBS when you are in high electric fields. However, I don't see indeed situations where you're gonna hang on top of your equipment plate for some reason and run the risk. However, something that we haven't discussed about is swimming after DBS surgery, because after surgery, some incidents of near drowning have been reported. So it is very important that right after surgery, the very first time that you go to a pool, you take someone with you, you enter in a shallow end, and people, may notice that the fluidity of their movements may be impacted a little bit. And just, to play on the safe side, take the shallow end, take someone with you, and then once you're good, you can continue swimming.
That's correct. Well, I think that applies more to the SDN target than the GPR target, but yes.
Yes.
Yeah.
And maybe another question that I do get a lot is driving. So usually, every country has their own rules. We in Belgium usually say that we prefer the patient does not drive for 6 weeks after surgery, taking into account whether or not the dystonia itself impacts driving, right? It's just the surgery itself. We usually say 6 weeks. Unless Dr. Akram, you have different habits in the UK?
Well, I mean, it's as you said, some patients with dystonia can't drive because you need to be able to do 180 sweep, and if you can't do that, you can't drive. But after DBS, I would, we usually say about 6 weeks, just to recover, make sure that there's no seizures, and if you have a seizure, then you'll have to surrender your license for a year until you're seizure free.
And yeah, so traveling, we talk about control at the airport.
Yes, we're speaking about the airport. Another thing, flying.
Okay.
After DBS, you usually shouldn't fly for a month after DBS. And that's because sometimes there's air inside the head, and that air can expand in the cabin if the cabin pressure goes down. So we tell patients with DBS not to fly for a month after surgery.
Okay.
I have a few questions about the timeline of everything. So before the procedure, how long is that time, the decision-making time usually, before you?
Well, it depends a little bit. There's usually it's not during the very first conversation that the patient has with their neurologist and or neurosurgeon about DBS that they're gonna, sign up their name and be added to the waiting list. Talking about DBS is a process that has to grow, basically. So patients need to walk through the different options from drugs and Botox. And then, you know, maybe when the physician starts to notice that botulinum toxin injections are not really giving you a sufficient effect, then you start to talk about deep brain stimulation. And little by little, you start this educational project of this educational trajectory with the patient. You invite their families, you invite them, like you refer to them like a webinar like ours, let's say today. But then let's say once the decision making has been done, you have to take into account the waiting lists that are there at the different centers, which, for instance, in Belgium, I would say it's anything between 3 and 6 months, probably. I do know that in other countries, this waiting list can be a little bit longer than that, sometimes even up to a few years, unfortunately.
Okay. And then if it's decided then that I will have DBS, and how many days before, or is it a day before the actual surgery that I go to the hospital, or?
It's very different from center to center.
Okay.
So there are centers that ask you to come in the day before. There are centers that do it to ask you to come the day off, very, very early in the morning. Interestingly, in Canada, as Dr. Akram said, we ask the patient not to fly for a month. However, in Canada, I'm afraid that an exception has to be made now and then, because people do fly in from everywhere around the country to be operated on in Toronto. So, you know, every center has a little bit their own habits in that regard.
And then for the actual surgery, the implant of the DBS, how long is that procedure? How long does it take?
I could take that one.
Yeah.
Again, it depends on the surgeon, obviously, and the workflow. In my hands, it takes the actual procedure takes about 90 minutes, so an hour and a half. With this is putting 2 DBS leads in and a battery, so the entire procedure. Before that, what we do is we put the patient to sleep. This is how it will happen. Patients come into the anesthetic room. I say hi to them, and then the anesthetist will put them to sleep. Once they're asleep, we put fix a frame on the head, and then I work in an intraoperative MRI suite. So the theater is attached to an MRI scanner. So the patients have the frame on, and then the door will open to the MRI scanner. The table will move. They get an MRI scan straight away. And that will take 20 minutes, that process. Then the table will go back to the operating theater position. My fellow will then start prepping the patient, so they'll start cleaning and draping. At that time, I will do the planning. I'll come up to my office, I'll plan the surgery, and then by the time I finish the planning, my fellow will have finished draping the patient. So I come down with the coordinates for the target. We then do the surgery, which takes, as I said, anything between an hour and an hour and a half. We then move again to have an MRI scan or a CT scan, which is right next door. And that takes another 20 minutes. And we confirm, so we'll get where we ended up and where we wanted to be, and we have to be exactly where we wanted to be. If we're more than 1.5 millimeters away, as I said, we have to move it. That happens very rarely. If I'm happy that I'm in the right place, we will then remove the frame and wake the patient up. And that's the end of it.
Do you turn it on right away?
No. So we turn it on usually the day after surgery.
Okay.
Also there's some variability. For instance, in Toronto, we have the habit of waiting about 4 to 6 weeks. So we leave a little bit of time for the brain to heal, and then we ask the patient to come back in. But as said, every center has their different rules. There is no right, there is no wrong. Everybody just has their own, customs, let's say.
Yeah.
And what about the pain? Does the patient experience a lot of pain after the surgery?
Everything is, through very small incisions, so it's not generally a painful operation. We don't give patients opioids after surgery, so we don't give them anything that might make them sleepy. We give them simple painkillers, and that tends to be enough. The batteries are now very small. They don't cause irritation or pressure on the skin or the muscles. So it's a part of the operation. We have to pass a cable under the skin to get to the chest, and the way that's done is by using a tube. It's called a tunneler, and sometimes if the patients are very skinny, that is difficult to do, and the patients will wake up with a bruise on their neck, and that can be sore. Very rare for that to happen. Generally speaking, it's a very well tolerated operation. The surgery is it's very samey. It's very repetitive. And the surgeons who do a lot of this, just do this, it's a conveyor belt, do the exact same thing over and over again. The key to success is patient selection and programming after surgery. So it's, the work that Dr. Boogers does is that's really the main thing. The surgery bit is simple compared to other brain operations.
And how long do the patients stay in the hospital after the surgery?
They tend to stay for about a week after again, this is something that it depends. If you're going to program the patients 6 weeks later, they can just go home the day after. They don't need to stay in hospital to recover. We keep the patients in hospital so that we can increase the stimulation bit by bit every day. And then once we've reached a certain stimulation threshold, we send them home and then we bring them back within a week to do some more tweaking. They go home, they come back, 2 weeks later, then they go home, they come back a month later, 6 months later, and then it becomes once a year.
Okay.
And how many times do we need to find the right program for the patient, for the individual one?
It depends. So usually in Toronto and in Belgium, we ask the patient to come back 4 to 6 weeks after surgery, and then every second week 4 times. So that leaves us 8 weeks in total, and that's usually sufficient time to reach some sort of plateau. Every now and then we need 1, 2, 3 additional sessions. So that's why we say all in all, from the surgery to the day where stable parameters are being found, can vary anything between 4 and 6 months. However, as Dr. Akram mentioned in UCL, the approach is slightly different. So maybe there the parameters are found in a slightly faster way. We have the habit of working in what we call an outpatient setting, meaning that the patient comes in and goes home. And that's why to do accelerate the process a little bit, we do give them homework, meaning make videos, increase the settings themselves, change settings, and so on and so forth, because it is of interest for everybody that we do put in our best effort to make the best parameters available as soon as possible.
You mean that patients are able to change themselves the program at home?
Yes, sometimes we do ask them to do that, obviously only when they do feel comfortable doing so.
Okay.
Can I add just one thing? Luckily, this is not common, but it can happen. And dystonia is not generally a progressive illness. But sometimes we see patients who had responded really well to DBS, to stimulation, coming back years later with symptoms progressing. We don't really understand why that happens. And it's very frustrating and it can be quite difficult to treat. So sometimes the treatment would be just to increase the stimulation. Sometimes we have to operate again to use a different target in the brain, to go to a different part of the basal ganglia. And sometimes there's nothing we can do. That is rare, but we can sometimes see that the symptoms comes back, and that's when we need to try again to change the program. I don't know what Dr. Boogers' experience is with this.
No, absolutely. And this is a very or this can be, whenever it happens, a very frustrating situation for both the physician and the patient. And it requires effort and time of the physicians to still again and again try to find better stimulation parameters, which cannot always be found. This is the case for Parkinson's disease, where it's always worth a new effort to find newer parameters, but definitely in dystonia as well, although the success rate in dystonia is slightly lower in my experience than is the case in, for instance, people with Parkinson's disease. But as you said, it's an extremely rare thing to happen.
And what about extra electrodes? I think we have some patients who have four.
Yeah, so we do. So sometimes we put extra electrodes in the same target if there is space. So every person's anatomy is different. And sometimes we see patients who have, very big internal pallidum, and we can put two other DBS leads. Sometimes, we see patients who had surgery somewhere else, and then we look at the scan and we think, well, we can do a better job. So let's move these DBS leads, put them somewhere else. Or sometimes the DBS leads are just perfectly placed. There is no room for another one. We pick a different target, like the subthalamic nucleus target. The results the numbers are very small, so we can't tell, it's difficult to tell how successful this is. Also, these tend to be the worst of the worst cases. So the outcome can be quite variable. It's difficult, especially if we had a really good result to start with.
And what is the future of DBS?
That's a good question. I think people who are in research in neurology, neurosurgery are definitely very much engaged in trying to improve care for people with dystonia, with DBS and with other therapies. One of the things Dr. Akram talked about was lesioning, for instance, making a hole in the brain. We see that the brain stimulation devices are becoming smaller and smaller. We see that these devices are becoming smarter as well, right? Some of these devices are able to connect remotely from a distance, as mentioned, but also they are able to analyze some of the brain waves that they pick up from the brain. And sometimes in some of these devices, they can even program the device in such a way that it takes into account the feedback that it gets from these brain waves. So really trying to individualize the therapy of the DBS device that we give to these different patients. But there's a lot going on actually, because even brain imaging, something that Dr. Akram is highly specialized in, is increasingly become more specialized and individualized to really make treatments available on the level of each individual.
Yeah.
Okay. Good. I think we are at the end of the time.
I just had another question
Yes,
from
please,
a patient. Yeah, it's about severe head tremor and if DBS is effective for that.
So if it's dystonic head tremor, then yes, DBS can be quite useful for that. We have another target as well, which is the VIM. It's also good for tremor. It depends if it's type, if it's linked to essential tremor or if it's a dystonic tremor, then the GPI is a good target. But we need to operate on both sides of the brain to help with that. It's again, it's there's no 100% improvement, but it tends to respond. What do you think, Dr. Boogers?
Yeah, no, absolutely. And we have to take into account when we do VIMs on both sides that sometimes speech is a little bit affected. So those are discussions that we have to do with our patients. It's, as we said in the beginning, when we stimulate the structure that we want to target for dystonia, that we are close to other structure, for instance, the light flashes that we discussed, if we then move to a different target, like the VIM, speech, sometimes gait, stability of the gait can be affected as well. So especially if you target both sides of the brain, it's important to talk about this.
What is VIM? What is
ventral intermediate nucleus of the thalamus? It's slightly more, it's slightly a few inches off.
Yeah.
okay.
Millimeters, not inches.
Millimeters.
Okay.
Yeah, it's a different target in the basal in
Yeah.
the brain. So it's in a part of the brain called the thalamus.
Okay. Thank you. Yeah, I think we had a lot of questions left. As I have written in the chat, I have written the email of the Secretary of Dystonia Europe, so don't hesitate to push your questions there. So I will close the webinar. So thanks to our speakers for this great time and information. It was really appreciated. Thanks to the audience, and Zoom will propose you a short satisfaction survey when disconnecting. So please fill it in. We always appreciate your feedback. You have a comments field. You can write your extra questions here too if you wish. So thanks to going on following us on social media for this Dystonia Awareness Month. Don't hesitate to like, comment, share, and take care, everyone.
Thank you so much.
Thank you so much.
Thank you.
Thank you for the great questions.
Bye.
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 Bye.